In this episode, I talked to Dr. Maria Fiatarone Singh. She's my professor in a class called Exercise Across the Lifespan, which is a class that I'm taking here in Sydney, Australia, during my study abroad. Maria completed most of her formal education in the US, notably at Stanford and at UC San Diego. She was also an instructor at Harvard, where she did a ton of her research. Now, here in Australia, she's been the chair of exercise and sports science at the University of Sydney since 1999, and she even opened her own geriatric clinic where she prescribes exercise to her patients. This is definitely one of my favorite episodes so far. I love learning about exercise and longevity, and here she tells me a ton about why doctors don't prescribe exercise to their patients. We also talk about big pharma and the problems with current medical education. There's a ton to learn here, so sit back and enjoy. You are now listening to the Gustavo Franco podcast, where we challenge the norms and uncover the truths of our healthcare system. I'm your host, Gustavo Franco. Hey, Maria, thanks for joining me today.
My pleasure.
Throughout our class, I've been super interested in every topic that we've talked about. I'm like a longevity and exercise geek, and then you pair that with the actual medicine that you do at your clinic, and I think everything is just so beautiful and interesting. So I'm super excited for a discussion today, super curious, have a ton of questions. To start off, I know that a lot of people talk about exercise being the magic pill for like all conditions, and also as a preventative pill, right? Would you go further than that and say that strength training by itself could be a pill like that as well?
Well, I think as you go through life, I think your need for strength training increases rather than decreases, which is what most people think. And that's because of some of the biological changes that happen to the body, particularly loss of muscle and bone. So I think absolutely for those conditions, it's pretty much the only kind of exercise that really helps prevent that loss of muscle and bone. And also as you get to the sort of last decades of life, when things like frailty and disability start to creep in, becomes very central as the type of medicine that you need. Not that aerobic exercise isn't necessary, but certainly the core of what you do tends to be more strength focused rather than aerobic the older you are, I would say.
Yeah, no, I like that you bring the later in life here, right? Because at least with my grandparents, I've told you this before, but there seems to be this connotation that exercise can be bad for you at old age because you're going to get injured or you're not supposed to be lifting weights at old age. Why do you think this connotation exists?
Well, I think traditionally it's been thought that as you get older and frailer that you have to back off on doing physical things. And some of that's cultural, like in non-Western cultures in particular, it's considered a bit disrespectful to make your older relatives do heavy work or lift heavy things. And so I think there's that. And then there's a lot of probably misconceptions and fear on the part of certain physicians and other healthcare practitioners that it is dangerous to do exercise that is either intense or robust in some way. But it's really the opposite. What we've found over many decades now actually is that the body is pretty much the same in terms of response. And if you want it to adapt and to get stronger or to get fitter, you really need to be using those same kinds of intensities that would work in a young adult. In absolute terms, they're different, but in relative terms, they're the same. So working at somewhere between sort of 75 and 85% of your peak strength or aerobic capacity, that's what makes your body adapt optimally. And that doesn't change just because you're 90.
Right. And I love that you brought up the point of frailty there, which is something that we talked a lot in class. Frailty seems to be like a natural thing that everyone gets as they age. Should it really be seen as a natural process, or should people not really accept that they are going to become frail and try to prevent it in the best way possible?
I think it's not uniform. I think a lot of people do get it, but even at late stages of life, not everyone is frail. So it becomes more common. Maybe 25% of people might be frail after the age of 75. That would go up a bit after 85. But there are people who age robustly, and some of that is obviously genetic. Some people are very genetically blessed, particularly the people who live to be centenarians or super centenarians. They are a bit genetically different, but lifestyle has a lot to do with it as well. And I think some of the studies of master athletes do kind of give us a clue as to how much is preventable and how much is related to lifestyle versus just biological aging. So if you look at a master athlete, for example, an aerobic master athlete, they will have the glucose homeostasis, or the ability to control blood sugar, very similar to a 20-year-old. As soon as they stop exercising, they lose all of that. So there is a huge role for exercise to actually prevent frailty and prevent some of those changes that we think are maybe immutable. We can't prevent people from aging and dying, certainly, at least at this stage. But I think we accept a lot more disability than we have to, and particularly premature disability that happens when people are 65 or 75. We probably can compress that a bit more to the last couple of years of life rather than having it gradually sort of creep in from age 65, 70 onwards.
I think it would be interesting here to define frailty. I know it's a very complex concept. We had multiple slides in class trying to define it, right? But in the simplest way possible, what is frailty? And then what's the role of exercise, specifically strength training, and first preventing frailty, but then also once you are frail, slowing down the progression of frailty.
So I think frailty is, although there are a lot of definitions, the most common sort of concept I think that links them is that your body isn't able to respond to stress in the way that it used to. So if you think about like a tall building, for example, it's built to respond to stress by swaying in the wind. Whereas if the building was very rigid, for example, it would crack and break in a windstorm. So the body is very much like that. And when you're young, everything's very fluid. And if you get stressors, whether they're internal or external, you can adapt to them, and your organ systems know how to kind of communicate with each other. The older you get, the more sort of rigid the body systems become. And so the slightest little stressor can knock you over the cliff. So that's really what frailty means, is you're not able to respond to stressors and kind of become resilient again. And to try and sort of operationalize it, we usually measure people in terms of their things like their muscle strength, their walking speed, their physical activity levels, whether their body weight is changing over time, and whether they feel tired all of the time. Those are some of the common ways of defining it. So it's a little bit different than just knowing how many diseases somebody has, because you could have 12 diseases and not be frail. Mm-hmm. Or you could have one disease and be quite frail. So it's really not the cataloging of diseases. It's really knowing whether or not the person has change in terms of their robustness. So resilience is kind of the opposite concept to frailty. And when we think of somebody who's resilient, we think, well, if they got sick, they would recover quickly. If they if they lost a spouse, they wouldn't, sort of go psychologically down and never recover from that. So they're able to rebound from stressors. So that's what a resilient person is. It's somebody who's frail, whether it's a psychological stressor or a physical stressor or an immunological stressor or an infection, they don't bounce back the way they used to. And that's the frailty. So exercise looks like, from the studies that we know, that people who are physically active for whatever reason are less likely to become frail. They age in a way that's more robust. And again, we don't know why those people exercise. So it could be genetic. It could be that people who are destined not to be frail are also the ones who like physical activity for some reason, because we can't really prove it.
In that there's a genetic component that makes you more likely to want to exercise?
Exactly. And we've seen that there are animal studies, for example, that show that animals that like to exercise, they have a different physiological response to intense exercise. And in humans, it's actually been studied as well that some people find it very noxious if they get like a rise in adrenaline. That feeling of adrenaline circulating is actually a very negative, unpleasant feeling, which would dissuade you from wanting to do robust exercise. Other people love that feeling, right? The ones who like to jump off cliffs, they're adrenaline junkies. They actually thrive on that feeling of adrenaline. But that seems to be genetically driven. There are differences in the genome, the epigenetic profiling, that suggest people might go one way or the other in response to epinephrine. So that might be why some people like exercise, other people don't, or it might be a combination of that and sociocultural factors and opportunity, et cetera. So there are differences, and you can't prove that you can prevent frailty by looking at those kinds of studies because they're just observational. And if you were to take people and exercise them for 50 years and then randomize them, into exercises or not, you could do an experiment, but nobody can do those kinds of experiments, obviously. So most of the experimental data is on people who have become frail or pre-frail, where they're just kind of merging into that. And then you exercise those people and you see whether or not they do better than people who are sedentary. And those kinds of studies do show that exercise helps. And the kinds of exercise that have been studied are usually either resistance training by itself or the combination of resistance training with balance training or even aerobic training as well. But usually it has a core of resistance training because many of the features of being frail are things that look like what happens to you if you don't do any strengthening exercise. You lose strength, you lose muscle, you get slower, you get weaker. So all of those things that are kind of features of frailty are things that can be addressed directly with resistance training, but aerobic training doesn't really change those things in any kind of direct way.
Okay, this is interesting, the potential genetic component of it. I feel like even in my personal life, I see this when I go into the gym with my friends. Mm-hmm. I love working out. I absolutely love it. I like working hard. When I'm in the gym, sometimes we'll do drop sets on the leg extension. And this is the one that gets all of my friends, right? We'll just go and like do 12 reps and put the weight down and do 12 more reps, put the weight down, do 12 more reps. And my friends like hate it. They never want to do it again. And for some reason, after I get off like the leg extension machine, I can barely walk, but I'm like, oh, this feels great. This feels great.
So you like that feeling of, exhaustion and adrenaline. But I think there, very much, it's very likely that there are genetic components, just like there are genetic components to how well you adapt. So we know from like the family heritage studies that Bouchard and others that there are these genes that sort of determine how much aerobic capacity benefit you'll get from aerobic exercise. There's 9 different genes that seem to dictate that. And you can do exactly the same amount of exercise, and some people will get no change in aerobic fitness, and other people will get a 20% increase in aerobic fitness with exactly the same exercise measured in a lab. And that genetic component, is not something that you can change, obviously, but it's certainly, part of why we respond, and it's probably also part of why people either choose or don't choose to exercise.
And do you reckon that this genetic component that makes you more likely to want to exercise also makes you more likely to live longer?
I don't know if that's ever been studied. Yeah, I'm not sure.
Okay, that would be kind of interesting to look at.
I mean, if you look at the long-lived people, the blue zones around the world, Sardinia and Okinawa and a couple of other places, you see sort of patterns of behavior that are similar in some ways, like usually being quite physically active for long periods of their life, not overeating large quantities of food, being a very socially connected community. So they're sort of and then there are obviously genetic features because they're living in these little zones where there's a lot of intermarriage and things. So I think it's a combination of all of those things. But, whether or not that kind of a high level of physical activity with a very sort of, life that requires farming and those kinds of occupations, whether that is genetically mediated or just socioculturally mediated by their, surroundings, it's hard to say. I mean, most things are a mixture of both. I mean, there's very few things except for specific genetic diseases that are, only genetic or only lifestyle related. It's unusual. So
yeah. So that popped up a question that I've always kind of had. So in the blue zones, people eat usually less than the average person, but they also exercise more. So is there a correlation between how much you eat and how much muscle you can build? Because I would think that the more you eat, the more muscle you can build. And the more muscle you build, the more likely you are to prevent these conditions that we're talking about. But then, so is there like a balance between how much you should eat and how much muscle you can build?
Well, yeah, there is. And frailty is also linked to obesity. So it's linked to sarcopenia, low muscle mass, but it's also linked to obesity. And the most common condition of aging in terms of body composition is sarcopenic obesity, where you've got too much fat and too little muscle. So I think people in those zones, they tend to be lean. There's very few people who are obese when you look at them, and they're not eating a lot. So they're kind of matching their food intake and their caloric expenditure. Whereas in many Western cultures that aren't so long-lived, they're not very physically active, and yet they're still, because they have access to food, they're actually eating more than their requirements are. So they're actually adding fat more than muscle, and they may even be losing muscle while adding fat and either staying the same body weight or increasing in weight. So Yeah, so I think in the blue zones, they tend to be lean. They tend to have a good amount of muscle for their size. So they have certainly the ability to, carry their body through space because it's not composed mostly of fat the way it might be in other people.
Right. So when you look at them, even though they might not have the most muscle as, say, like a bodybuilder,
yeah,
their strength proportionally to their body size might be
exactly
higher. And so what's the importance, say, strength versus actual muscle size
mass
and hypertrophy?
Well, I think for different things. So metabolically, it's great to have big muscles because muscles are the sink for your glucose and where you store glycogen. And so if you have a large mass of muscle, you can basically store a lot of glucose and your blood sugar is not going to rise when you eat. And you're also immunologically better off because you don't have to use sort of break down skeletal muscle to make antibodies because you have plenty of, other sort of proteins around. So certainly having enough muscle is important metabolically and immunologically. And actually it's been linked to bigger brain size as well. So it seems to be going in that sort of same direction. In terms of strength, basically that is more closely linked to function than muscle mass is. So if you want to think about how fast somebody walks or how much time it takes them to get out of a chair or do their daily activities, strength seems to be more important than muscle mass. So when you're young, they're kind of, pretty well matched. You can tell how strong somebody is by looking at the size of their muscle. As you get older, that dissociates. And it dissociates for a couple of reasons. One is that the muscle is not all muscle. There's a lot of connective tissue and fat in it. So when you think it's a certain size, only a portion of that is actually contractile muscle cells. And the other is that your brain gets less adept at recruiting muscle fibers. So even if you have the same number of muscle fibers and they were the same size, when you go to do something, your brain doesn't recruit as many as it used to or as fast as it used to. So there are changes in strength that happen sort of separate from the changes in size. So I think they're both important, having bigger muscles and having stronger muscles, but they're quite different. And some of the studies that have been done over the years by pharmaceutical companies trying to, develop a drug to prevent or treat sarcopenia, what they've done is, in the past, anyway, was focus on drugs that increase your muscle size, like growth hormone and growth hormone analogs. And unfortunately, when you do that, the muscles get bigger, but the person doesn't get stronger. And often they get other things like carpal tunnel syndrome and diabetes, other things. So to make the muscle stronger, you actually have to, do functional activities that recruit it, and it adapts to that kind of accelerated sort of force production. But just having bigger muscles that are never trained is not really that helpful. So people who are obese, for example, they have more muscle mass than people who are lean, because as you get more muscle mass, you put on a bit of, or more body weight, you put on a bit of muscle, but they're not necessarily stronger. They just have more muscle and more bone, but it's not as functionally active as somebody who's quite lean. But the strength training, they will actually have a much more functional, small body of muscle, essentially.
So correct if I'm wrong here. Strength training and function, and then muscle size and, say, metabolism.
Yeah, I think that's probably, not, completely, but that's probably a good divide. Yeah.
All right.
Yeah.
Interesting.
Yeah.
Interesting. And then something else that you brought up here was the size of the brain, how exercise can actually increase the size of the brain. I feel like there's this negative connotation that spending more time exercising makes you spend less time in school and then you become less smart. Right. For some reason, there's this connotation. They say like, oh, the gym bros, they don't.
Yeah. Brain versus brawn. Yeah.
Exactly.
And I think it is a stereotype that is out there, and, and maybe somewhat rightly deserved in some corners, but, or maybe, people who do certain kinds of activities that cause brain damage, like boxing, for example, or other kinds of activities that cause, multiple head trauma or concussions. But other kinds of exercise that are done without damage to the brain in terms of injury, both aerobic training and strength training have been shown to increase different parts of the brain or functions of the brain, or even in Parkinson's disease, certain kinds of enzymes that help promote dopamine activity, for example. So we're finding out more and more that, in general, both kinds of exercise are stimulatory for the brain, but probably in different areas of the brain. Yeah.
And is that directly, so say the increase in brain size, is that directly related to improvements in cognition?
Yeah. So some people have shown that. We've shown it in studies looking at strength training. that the change in the size of this certain part of the brain was related to the improvement in cognition. Other people have shown it in aerobic training studies. So, it's not a one-to-one correlation, but when it's been looked for, it's often been found. That's right.
Okay, interesting. I feel like a lot of the listeners are younger, so it would be interesting to focus on the preventative measures of exercise as well. I want to generalize things. Let's break down a life but in like quarters, right? Say a long life, someone that's going to live to 100.
Okay.
So 0 to 25, 25 to 50, 50 to 75, and then 75 to 100. What should they be exercising for, and like what should they be trying to achieve at each of those quarters? And
Right. So in that first 25 years is really the period when you get your peak pretty much of everything. So bone by age 19, muscle mass maybe by age, and strength by age 30. So in terms, and aerobic capacity, again, maybe by age 30, 35. So in that first quarter, you're really trying to reach your full genetic potential. So hopefully if you've had a good intrauterine experience, and if you've had good childhood nutrition, and haven't been exposed to toxins like alcohol and smoking, then basically you want to do a combination of exercises that going to maximize your aerobic capacity and your muscle strength and bone mass. So that would be, a combination of aerobic and strength training activities, and probably also when you're very young, obviously as a baby, it's kind of about coordination and neuromotor control, and just crawling around the environment, you sort of rev up those things. And, that agility and coordination is also something that you can kind of optimize in that period of life. So it's really about getting your body as fit as possible for the rest of your life, and also preventing any risk factors for chronic diseases that occur later from starting. So we know that even like coronary artery disease starts very young in childhood, probably. Losses of bone can, if you have, for example, an eating disorder and other kinds of negative influences on bone, you can get, osteoporotic stress fractures as a teenager. So preventing those things from happening is the primary role. And the other role, I think, probably for adolescents and young adults is mental health. So there's a lot of research that people who are physically active would prevent the development of things like depression and anxiety and insomnia and substance use disorders. We don't know if you could prevent, first episode schizophrenia, first episode psychosis, for example, which happens around 19 or 20 often. But certainly for the non-schizophrenic mental health concerns, there's a lot of evidence that exercise would be helpful both in prevention and treatment. And those diseases do occur in adolescence, obviously. In the second phase, really 25 to 50-ish, there's where you're really focusing on risk factor reduction. So you're trying to prevent obesity, hypertension, glucose intolerance, all the sorts of things, hyperlipidemia, that are going to, predispose you to cardiometabolic disease, in particular, and cancer as well. So the kinds of exercise that do that, again, are generally reducing sedentary time or breaking it up, number one. And then, again, that combination of aerobic and strength training. And, most of the literature is about aerobic training in this sort of phase, but there's certainly evidence that most of the things that we have attributed to aerobic training, like lowering of blood pressure and prevention of glucose homeostasis problems, can also happen with resistance training. So I think it's kind of either or. You don't really need to be stronger because you're strong enough. So what you're trying to do is really prevent risk factors for chronic disease. And then when you get to kind of 50 to 75, that's when these chronic diseases are starting to emerge. So then you're getting hypertension and heart disease and diabetes and obesity and arthritis and depression and all of those kinds of things. And I think there it's often a matter of maybe the combination of lifestyle things like diet, avoiding alcohol and tobacco, and, focusing maybe a little bit more on the anabolic exercise, because your muscle mass, it probably stays the same from about 30 to 50, but then it's really starting to decline, maybe 40 to 50. And once you hit, menopause, then you're certainly, in the area where you're losing muscle and bone quite rapidly. So again, sort of some aerobic, obviously still, but thinking a lot about adding strength training if you haven't done it. And then 75 to 100, that's when things start to change with your neuromuscular system again. So balance gets a little bit off. And so you need to think about a way to incorporate balance training in your regimen. The anabolic exercise becomes even more important than it was at midlife. So more and more focus on strength training, still doing the aerobic if you can. But if you've, gotten to a stage where aerobic exercise is really difficult because of arthritis or peripheral vascular disease or mobility problems or falls or frailty, then you're going more and more towards strength training because the aerobic, exercise becomes very difficult, or if you get like a degenerative disease like Parkinson's disease and it's got to a stage where you really can't walk very fast or very far, you can still sit on a machine and do strength training and get a lot of that benefit. So I think the paradigm kind of changes from, childhood where it's really all about kind of, neuromuscular control and play, a lot of aerobic activity in those early years, adding some strength training, and then really focusing again on strength training at the end and balance training. Strength training you don't need to do as a baby because just as you're getting bigger, you're strength training just by lifting your body weight against gravity. And so you're kind of naturally strength training every day, right? Every day you gain a few more ounces. And so every day your muscles are getting bigger. So you don't really need to do it, but you are doing it unconsciously. And at the end, again, you need strength and balance training, number one. And then if you can add aerobic to it, or because now you've gotten, better mobility, then you add that as well for more benefit.
I think it would be interesting to look here at skeletal muscle, bone, and cardiovascular function. Throughout this time, how does that change? Like, when do you peak? When does it start slowing down? When does it really start slowing down? Is it different for like men and women? I feel like that would be interesting to talk about.
So for bone, like say you peak your bone mass at about age 19 or 20, and it stays about the same, and that's in men and women. And the degree to which it goes up depends on what's happening around the time of puberty. So if you exercise before puberty, you get a massive increase in bone density, bone mass, whereas if you don't start till after puberty, exercise does improve it, but not as much. So critical time is that sort of few years before puberty. Then it stays about the same in terms of bone mass until you hit menopause if you're a woman, at which point you've got about 10 years of kind of a more rapid decline. And then it levels off again, 60 to 100, a gradual decline. Men are exactly the same, except that there isn't that steep decline from 50 to 60, but there is a linear sort of decline after age 50 in men as well. So those changes are due to the loss of sex hormones, men and women, which is more drastic in women, but occurs in men as well. So that's with bone density. And because bone density and bone mass are related to fracture resistance, basically the fracture risk generally parallels the changes in bone mass, except for in children where there's a lot of sort of risk-taking behavior, and there's lots of Colles fractures from skateboarding and things like that that don't really have to do with a disease of the bone, but have to do with risk-taking behavior. In older adults, you don't really need to take risks to fracture if you've already kind of gone below that fracture threshold, which is about 1 gram per centimeter squared. When your bone is less dense than that, it's easy to fracture from just standing height, which we call a minimal trauma fracture. So that's bone, and bone is very responsive to, very specific about what it responds to, and it responds to high forces, high loading forces, or high impact forces, or forces coming from different angles and coming rapidly to the bone, and it saturates very quickly. So that means something like jumping is really good if you can do it, or other kinds of high impact sports. But the other thing that works if you don't want impact is just weightlifting exercise at a high intensity. It also puts a lot of load on the bone. And so the way that you use that is to kind of figure out whether your person has arthritis as well as osteoporosis, or if they just have osteoporosis or just have low bone density. That will dictate whether you can use high impact training or whether you have to stick with high load, low impact, right? So high load, low impact would be like hiking. A high load, high impact would be running. So you don't advise running and somebody's got arthritis, but hiking is okay, for example.
So if I jumped a lot, because I played volleyball throughout high school, so I did a lot of jumping, but I only really started working out at age 17, which I think was after puberty for me.
Yeah.
Is that too late, or was I able to?
No, jumping is the most effective. So jumping, particularly if you're jumping, sort of high forces and different angles and, any kind of plyometric or volleyball or basketball. So that's really good for bone. And you don't need to do weightlifting exercise at that stage of your life. And I think the relative increases in bone density are greatest with jumping. The problem with jumping is that as you get older and you develop arthritis and injuries, you can't do it. And so then you've got to switch over to weightlifting as the way to maximally stimulate bone, usually. Some people can still do both, but that's how you sort of decide how to approach it. But high impact and or high loading, or one or the other is the most sort of potent exercise that you can give to bones. So simple walking doesn't do it, unless you have been away from gravity for a while in outer space, and then you come back, or you've been in bed for months and then you stand up. Gravity is not a stimulus to bone because it sees gravity all the time. So that's bone. Your second question was about muscle, I think?
Skeletal muscle, yeah.
Skeletal muscle.
When should you be aiming to really peak?
Peak at it. Well, you continue to put on muscle till you're like 30, so it doesn't peak at 20. It's, you look at, certain sports where, you need that, don't necessarily peak at age 20, but tennis players and basketball players often are still getting better through their 30s, and they're, still gaining muscle size and muscle function. So it peaks around 30, stays about the same for about 2 decades, and then it starts to slowly wane again with the hormonal changes of older age. And, muscle is quite specific again in its requirements. You really have to expose it to a force that's not customary. And as you get stronger, you have to increase that relative load so it always feels hard. So that's progressive resistance training, what we call, and that doesn't change. That principle, that philosophy is the same in a 2-year-old as it is in a 92-year-old. And I think what's happened in the past is that people have assumed that somehow the equation changes, and that just because you're old, it no longer follows that principle. You can get people stronger even without making them lift a heavy load, relatively heavy load. And that's just not true. It's very clear from, all the studies that have been done that almost every clinical outcome you look at after strength training is better if you do it at a robust level. The only exception to that is arthritis, where if you're looking at change in pain, it seems to get better whether you do low, moderate intensity weightlifting. But every other outcome, whether it's dementia or depression or heart disease or diabetes or Parkinson's disease or stroke or insomnia or cognition, any of those outcomes actually have a dose-response relationship between the intensity of the strength training and the clinical outcome. So it's very much like a drug. It's not, it's very much like a drug. There's a certain dose that works, and doses below that are actually either placebos or just suboptimal in terms of their usage.
And what does, say, genetic potential really look like here? Because I feel like someone can really push themselves in the gym and go kind of crazy, which is honestly what I did at age 17 through age 20 or 19. Like I would be in the gym for 2 hours, go like extremely hard. I didn't get injured, thank God, but like I was doing crazy drop sets, really pushing myself to the limit. Is that what you want to be doing, or do you want to be doing something slightly more comfortable?
Yeah, well, I mean, it depends what your goal is. I mean, if you want to exceed as a bodybuilder or a power lifter or something, yeah, you have to be exercising like a maniac. If you just want to maximize your health status and prevent frailty, you don't need that. You can do much less of that in order to kind of keep, muscles quite strong. And I think, there are, certainly risks to some kinds of very competitive kinds of weightlifting that do cause a lot of injuries, and probably, combined with maybe diets that are not, completely healthful in terms of the amount of calories and protein in them. And, so there are things you can do that are extreme that will definitely increase your muscle size, like sumo wrestlers, right? I mean, there's extreme amounts of calories and muscle building activities they do. They tend to die pretty young of heart disease. And so all that exercise is not doing them much good. So you don't need that for health. I mean, if you want it for aesthetics, that's fine. But you certainly don't need that level of exercise for health, I would say.
So would reaching genetic peak in bone density be more important than reaching genetic peak in muscle size?
It's hard to say. I mean, I think in terms of just aging as well as possible, they are kind of in parallel. They do, they peak slightly different times, but the kinds of things that make them reach their peak, good nutrition, no smoking, no alcohol, anabolic exercise, all of those things affect muscle and bone the same. So I think they're both important for healthy aging, obviously, and you don't need to have different kinds of lifestyles to achieve that in both of them.
Sure. Now going on to cardiovascular function, how does that change over time? Is there a peak?
Yeah, so that VO2 peak tends to peak around 30, so it's a little bit later than bone, certainly. And it, again, tends to stay relatively okay for a couple of decades, and then it goes down typically with aging. how fast it goes down is contributed to by lots of stuff in terms of both genetics and lifestyle and other diseases in particular. So lots of diseases would impair aerobic capacity. Some of it's about the heart, getting blood to the extremity. Some of it's about the muscle, how well the muscle can extract oxygen from blood that's flowing to it and and contract in response to that. And about half of you lose quite a bit of aerobic capacity with aging, and about half of what you lose is due to your loss of muscle. The other half is due to other factors. So it's not all about the heart. It's called the central role of the periphery, and that central role of the periphery becomes more and more important the older you are because you're losing that periphery. Or if you have a disease that causes muscle wasting, and some of the diseases that we think of that are heart diseases, that cause low aerobic capacity, like congestive heart failure, for example, those are inflammatory diseases, and you get what's called cardiac cachexia, which is a skeletal muscle wasting due to your cardiac disease because of the inflammation. So that loss of skeletal muscle is one of the most important parts of the clinical features. And even if you can't change the heart, you can improve somebody's exercise capacity enormously by just training their legs without worrying whether or not you can actually change, because you can't change the heart. Once the ejection fraction is low and you're down at 20% rather than, 60% ejection fraction, you can't fix that. You can get rid of extra fluid with diuretics and things, but you can't actually fix a failing myocardium. But you can make the periphery much better at extracting oxygen and doing muscular work. And so your exercise capacity goes up a lot, even with no change in your heart function at all. So we've done a study, for example, in older women with heart failure where we just instituted weightlifting exercise. They were in their 80s, quite significant heart failure. And with the weightlifting exercise, they were able to markedly improve their 6-minute walk distance and their enzymes. We did muscle biopsies, so we saw the oxidative and enzymes in their muscle were much improved without doing any aerobic exercise, just by doing the weightlifting exercise. So lots of ways to get kind of at the same problem, but muscle is much more treatable in a sense than the heart is.
So given that you peak at, say, age 30, you can actually retain most of that VO2 max if you're doing both cardiovascular training and strength training, as opposed to just doing cardiovascular.
Yeah, I think you retain more of it if you do both, but you can't retain all of it. They're, master athletes who've been running their whole lives, they have much lower aerobic capacities than younger aerobic athletes. And if you look at the peak times, the record holders, right, for any event, whether it's a marathon or 800 meter or 100 meter, the times go down even among elite athletes with age, right? There's no 90-year-old runners who can run the same speed as elite runners in their 20s. That doesn't happen. So there is a portion that you lose, but that 90-year-old elite runner will be much better off than his peers, but he will have changed compared to his 20-year-old self.
Mm-hmm.
Yeah.
So then if you had to pick one between strength training and cardiovascular training, I feel like we would pick strength training.
Well, I think it hits more things. I think it hits more because the things that are missing from aerobic exercise are the muscle and bone components. Everything else, they pretty much all do, right? Everything else, head to toe, they both do. You get a little bit more aerobic capacity benefit from aerobic training, particularly if it's HIIT training, high intensity interval training. But if you just do moderate intensity aerobic training and compare that to high intensity weightlifting, for example, if you're a sort of middle-aged or older adult, you'll improve your aerobic capacity by about 10% with either one. If you want to get to 20% improvements, then you have to be doing HIIT training, something that's very different in terms of intensity aerobically. So, whether you can do HIIT training or not, it depends on a lot of things. But, in some people, it's better because it's shorter, and people like that. If for a lot of outcomes, the changes clinically are relatively similar between HIIT training and moderate intensity continuous training. The thing that's most likely to be different is the aerobic capacity itself. But if you look at glucose control or, other kinds of things, relatively similar. Although there is some emerging data now in Parkinson's, which I've just looked up, which shows that the HIIT training or some variant of high-intensity interval training is actually better for Parkinson's disease symptoms than just moderate-intensity aerobic training. So there seems to be an intensity gradient for Parkinson's disease. But, for a lot of health outcomes, not that different. So it depends kind of, how much time you have and whether or not you can tolerate the high intensities or not.
Cool. I want to touch on blood pressure. You brought that up earlier, and hypertension. I know it's super common, so I think it would be cool to discuss it in detail here. You sent me that paper from the BMJ that was published last year, a meta-analysis looking at different types of training and the decrease in systolic blood pressure that they saw. So I printed it out here. And in order of most beneficial, being that it decreased systolic blood pressure the most, first was isometric exercise training, which decreased systolic blood pressure by 8. Then it was followed by combined training, so resistance training and aerobic exercise. And then aerobic exercise, dynamic resistance training, and high-intensity interval training were all kind of
all about
the same.
Yeah.
All about the same, yeah. What does this really tell you? Should people be doing isometric exercises? Because one of the things that I notice here is the effect size, right? We have a ton more studies for aerobic training, dynamic resistance training than we have for isometric training.
Right.
So how much should we really believe that? And should we be telling people to say, do wall sits or do leg extension holds, stuff like that?
Well, I mean, I think it's pretty convincing, I would say, when you look at the studies, and there definitely aren't as many of them, but they're pretty consistent. And, I would say, if somebody doesn't have a lot of time and wants to do something that's relatively potent for their blood pressure, and maybe they have pre-hypertension or they have a family history, I would certainly say, do isometric training. And the thing is, in the past, it's been the thing that all cardiologists have said you should never do, right? You should never do isometric strength training. It's bad for you. It's bad for your heart. And I think that was a mistaken conclusion from a few very early studies, where there were some studies where people did like a 30% of maximum hand grip dynamometer sort of holding for like 3 to 4 minutes. If you can imagine doing that, it's hard to do. And those kinds of studies showed that the blood pressure went up when the person did that. And that's nothing like what you do with either dynamic weightlifting or even these isometric training paradigms are not like that. They're more maximal for a shorter, period of time. So it seems to be quite beneficial. Whether or not I don't think it's the only thing you should do, because isometric training, is also quite specific in terms of the strength gains that you get. Usually get stronger at whatever angle the muscle is being contracted at, but not really, 15 degrees outside of that. So that's why we usually do dynamic training, is because we want people to be strong throughout the full range of motion, not just at 60 degrees or whatever of extension. So I think it's good as a part of your training program. It wouldn't ever be the only thing you do, because it's one muscle group usually. Sometimes it's only hand grip, so that's not going to help your legs or anything else. But I think it is good to know that, in fact, the effects are quite light. And even the effects of the aerobic and the strength training are as large as you get with medication, with a single medication. So I think people haven't given it a fair shot. They, as soon as somebody has high blood pressure, they start them on a medication without seeing whether or not they could actually lower it, similar amount with exercise. And usually there's a lot of other benefits to exercise than just lowering the blood pressure. Antihypertensive, usually that's all it does. But of course, if you prevent hypertension, you do prevent dementia and stroke and, lots of other bad outcomes. But exercise is a bit broader than just its effect, obviously, on the blood pressure. So, for me, if you had somebody who was newly hypertensive or pre-hypertensive and you wanted to start with something, then, I would probably start with isometric training. And then once they have gotten that and it's down, add other kinds of exercise as well.
Do you think that it also plays a role in preventing hypertension later in life? So should a young person be doing isometric training?
Yeah, I don't know that. I mean, certainly aerobic exercise has been shown to, have a lower risk of developing hypertension and other cardiovascular diseases. I don't know that anybody has ever studied weightlifting exercise, or I haven't read it to see whether that would prevent hypertension. It's possible that it does, but it's possible that I haven't read those studies, so I'm not sure. I think, most of the evidence that we know about epidemiology and the prevention of disease, most of it is about aerobic exercise, because in the past, most people studying exercise thought that the only health-related kind of exercise was aerobic. And so they never even bothered to ask the question, do you ever lift weights? They would say, well, do you ever do exercise that makes you sweat and breathe fast? And they say yes, and then they'd follow you and see whether you developed heart disease. starting maybe 10, 15 years ago, people started asking the question, do you do weightlifting exercise? And once they did, they saw that, oh, well, it also prevents heart disease, it prevents diabetes, it reduces mortality, it prevents cancer of certain types. So now that we've asked the question, the benefits attributed to weightlifting exercise are kind of broadening into the preventive benefits that we've always attributed to aerobic exercise. And it's really just because we haven't asked the question in the past.
Interesting. Okay. Now, a question that I've always wanted an answer to. Say you are a physically fit 21-year-old and you have all the time in the world, all the will in the world. What should you be doing, like, say, per week? How much strength training? How much cardio? How much maybe HIIT training, stability training, stretching? Like, what?
This is all you do with your life? You have nothing else to do?
No, but I feel like it would be interesting to just hear what that would look like,
Yeah. Well, I mean, there are the most recent studies on mortality, for example, suggest that the optimum METs in terms of aerobic capacity associated with lowest mortality is 14 METs. So if that's your peak aerobic capacity is 14 METs, that's as good as you get. That's the nadir of mortality. And
what does that really mean?
Well, so that would be somebody who's pretty fit. So yeah, I'm not sure how to put it in terms of, so your aerobic capacity would be maybe 60 mils per kilogram per minute. So it would be, high aerobic capacity. That's kind of, and there's no sort of peak at which it starts to go down again. It's just that seems to be sort of the nadir. And if you look at, physical activity levels and mortality, not fitness, but physical activity, the public health recommendations are 150 minutes of moderate to vigorous a week, right? Moderate or 75 vigorous. That's about half of the benefit for mortality. So if you double that, if you're at about 300 minutes a week of moderate intensity aerobic activity, that's the nadir of mortality. So that's kind of, clinic, and that's all-cause mortality. And it looks pretty similar for cardiovascular mortality. So if you're at the public health recommendations, you're about halfway there. You might say, well, why did they set them there? Well, it's a dose that people can kind of do. 150 minutes a week is pretty doable. 300 minutes a week or 600 minutes a week, very few people can do that. And so although it is better and it prevents more diseases, it's not considered to be very realistic, right?
So after 300 minutes, you really start getting just like a diminishing effect.
Yeah, it doesn't get a lot. I mean, you get a little bit better, I think, between 3 and 6. If you look at the curves from Harvard, most of those studies, between 300 and 600 minutes a week, you might get a little bit better, but it's not a huge amount. You've gained, most of the benefit is going from 0 to 150, half of it. And then the other half is going from 150 to maybe, 500 or 600 minutes a week. Really no benefit after that in terms of mortality. Whether it would benefit you more in terms of other stuff, it's hard to say because so few people do that. It's pretty hard to study, right? And if you look at clinical trials of, treating a certain disease or something, again, those clinical trials don't extend beyond, the most anything, people would do would be like 420 minutes a week, like an hour a day. That would be the highest level of sort of a clinical trial. So in a young person, who's healthy, you're trying to prevent disease, right? And be as fit as possible. So clearly preventing disease, you'd be kind of there at around 300 or 400 minutes a week. Any more than that, you're just, you got nothing else to do. Strength training, 3 days a week works, 5 days a week, after that, diminishing returns. Unless you're trying to be a bodybuilder, it's different. But if you just try to do it for health, 3 to 5 days a week is really, what seems to be optimal in terms of adaptations. And there's some studies that showing like 5 to 7 days a week, you actually get diminishing returns and less muscle gain than if you stuck it sort of 3 to 5 days a week. So I certainly wouldn't, advise more than that. If you want to be on the high end of that, yeah, you can ramp up your strength training. So it's, power training. So you're getting power as well as strength. You can, make sure you've got some free weight exercises. So you're, you're doing as much in terms of stimulation of different muscle groups as you can and balance, as part of that. And for the aerobic bit, yeah, you get more aerobic benefit doing it at the higher end of intensity, whether it's HIIT training or just high intensity continuous training. Or even sprint training, where you got very short sprints of 10 seconds or a minute. Those are the high end of each of those. And so, yeah, you get more fitness benefits at the high end of those. Not as clear that you get more clinical benefits So, it depends whether you're stuck on kind of, making your fitness as high as you can. And you can do that without extreme sport. You can get your, and again, it's not always in your hands. Half of your aerobic capacity is genetic, right? Half of your muscle mass size is genetic. So only certain things are in your hand. And so to get extreme benefit when you're genetically not endowed means you might have to go out of your way to do, things that are a little bit crazy, or anabolic steroids or things like that. So you don't really want to go there, but for most health purposes, you don't need to.
So how long should those 5 resistance training sessions be?
Well, again, it's pretty much just exercising all the major muscle groups of your body. So whatever it takes you to do that, which might be 45 minutes or something like that. If you get to 2 or 3 hours a day, well, that's in bodybuilding territory where you're trying to do something quite different, which is, more aesthetically driven rather than health driven, I would say. So an hour a day would be plenty for weightlifting.
Sure.
Yeah.
So say if you break down everything that we talked about, 300 to 400 meters, minutes of cardio, and then 5 days a week of exercise training, that's about an hour long. So that would be like an hour of cardio 5 days a week, and then an hour.
Yeah, that's the high
exercise training.
Yeah, I think you're over the top there in terms of what you need, probably. Yeah.
Sure.
And more than that is, unless you're training for an event or a sport, it's not a health related goal. Obviously athletes are quite different. They're training, for goals that have nothing to do with health most of the time. Yeah, and those people, but you look at, what happens to them sometimes, like Michael Phelps, and, it's not always good. You look at cyclists and swimmers, their bone density is very low because they're in the pool all the time or on a bike all the time. So they're not necessarily, because they're achieving one goal, they're not necessarily maximizing their health outcomes in all areas. So I think you have to be a little bit careful, sort of saying, well, yeah, you could do that, but, is it the best overall approach to your health that, because you're going to need your bones for the next 80 years. So, if you dissolve them away from, spending too much time, not on land, what are you going to do to get that back? Because, usually you never get it back. Whatever you have, you lose, but you don't ever usually get it back more than a couple of percent, right? So, yeah.
And then what's the importance of stability training and flexibility training, both at young age and then at old age?
Right. Well, I think obviously when you're very young, you have no balance, you're falling all the time, right? When you're old, you have no balance, you're falling all the time. So it's very important at both ends, obviously. We usually don't go out of our way to train babies, in their balance, because naturally they kind of get better with time. People in their 90s, they naturally don't get better with time because they're on the losing end of that. So we do go out of our way to train them. So usually important at, after age 70, your balance starts to go down, and about a third of older adults, even in the community who are healthy, fall every year. I had a fall this morning, I have to say, walking out of my house in the dark on a rainy area with bags in both hands. So, it's very common to fall. And so you do need to do something. And the normal kinds of exercise that we do don't improve it. So aerobic training doesn't improve your balance, particularly if it's on like a bicycle or something. But even walking doesn't improve your balance. Strength training improves your balance a little bit, power training a little bit, but not as much as balance training itself, so we tend to add that on everyone after age 70, but particularly people who are falling or have osteoporosis who are at high risk. When you're a young adult, again, your balance is usually okay. You don't probably need to go out of your way to train it. Would you be more agile if you did? Yes, absolutely. And gymnasts and dancers are going to have, much better agility and balance than somebody who isn't in that sport. But do you need it for function or health? No. There is some evidence from some studies I've been collaborating with in Brazil that flexibility is actually very important for even mortality, believe it or not. It's not clear to me that it's actually the flexibility that makes you live longer, but the fact that the people who are flexible are different in probably a few ways that haven't been controlled for in terms of other kinds of physical activity and strength and things. So, but if, there's a maneuver you can do where you go from a standing position to sit onto the floor cross-legged and then get back up without using your hands. So if you could do that, you live a lot longer than people who can't. I can't do it. So there are, and that's sort of a flexibility and strength maneuver is what that is. Got nothing to do with aerobic capacity. So, why that is, and whether it's just that if people who have that kind of flexibility are different cognitively or have different, brain or neurological function, I'm not really sure. So we don't do a lot of strength stretching. We tend to do it at the end of our weightlifting, perhaps, if we need to. And even, there's a thought that, well, people who have arthritis, they should stretch for the arthritis and because they're stiff, right? But in my experience and in some of the studies that, when you make people stronger, their range of motion improves because their muscles are now stronger. Stretching by itself has very little benefit. It's okay as part of a cool down. But even for like preventing injury, it used to be thought that you should stretch before you run to prevent injuries. That isn't true. Doesn't prevent injuries. And if anything, it could cause them if you're stretching a cold muscle. So the only time to really stretch is at the end of an exercise session of some sort where the muscles are warm and the tendons are warm. And then, as part of a cool down, you could do it. As a thing by itself, if that's the only exercise you do, that's pretty much the control group of all the randomized controlled trials of other kinds of exercise. So we know it doesn't work by itself as a way to improve diabetes or depression or insomnia or heart disease or, anything else pretty much. So, we would never recommend it as a standalone exercise. We would always recommend evidence-based forms of exercise for whatever condition it is.
And you talked about the importance of stability training, specific stability training. What does that look like?
Well, we call it balance training is what we call it. And basically, it's your ability to withstand perturbations to your balance or, things that threaten stability. And so the principles of balance training basically are to do things that are threatening. So things like moving to the limits of sway, so going as far in each direction as you can without falling. Drawing vision makes it harder. Withdrawing proprioception, so if you're standing on a very compliant surface or on a pillow or a piece of foam, that makes it harder. Moving your center of mass away from the center, so kind of holding like a heavy ball in your hand and holding it away from your body mass and doing that. Narrowing your base of support is a very important principle of balance training, where you go from, kind of your widest base of support would be two legs far apart, holding on to a desk with two hands. The narrowest base of support would be standing on one toe with no hands. That's a very narrow base of support. So you basically, can look around at what people do when they're off balance. They tend to widen their stance or they hold on to something because that makes them more stable. So you basically do the opposite. You withdraw those things until you get to a place where the person is standing on one leg with no hands, with their eyes closed on a piece of foam, counting backwards from 1,000 in Chinese. That's not their native language, because that dual tasking, which is called a cognitive distractor to the physical task, makes it even harder to balance. So if you make your brain do two things at once, like standing on one leg and juggling would be two physical tasks, or standing on one leg and, reciting poetry would be a physical and a mental task. But whenever you divide the brain's attention like that, it makes it harder for the brain. And so you'll sacrifice one or the other. And you could try this yourself. As I've done this in class before, where I have like students do a heel-to-toe walk, the drunk driving test in America, tandem walk here. And, usually students can do that quite easily. But then I make them do it while they're reciting as many names of animals as they can, something quite simple. And as soon as you do that, they suddenly start to have trouble with the tandem walk because now their mind is divided into two different tasks. So even in healthy young people, you can see that it goes off. And in older people, it's even more difficult. And so you kind of, it's very much like strength training. Like if it's hard to lift, you do that because that makes the muscle stronger. So if it's hard to balance on one leg with your eyes closed, you do that because it makes your balance better. And it's the very same principle. As soon as it doesn't feel hard, you go up to the next level. So we call it mastery. So as soon as you've mastered a certain level, it means you can do it for 20 seconds, you don't fall over. Well, then we go on to make it harder. So it's exactly the same principles as aerobic training and strength training. It's that continuous progression of difficulty, which is what makes you adapt. And balance training is immensely trainable. It's one of the easiest things to train. You can double or triple somebody's balance very, very easily. Sometimes as you do the test, so even when we test people, we only do it once, because if you let them do it 3 or 4 times, they get better every time they do it. So even before your eyes, their balance improves as they practice. So you have to, make sure your testing is kind of different than your training if you want to prove that they actually got better from your training.
That's cool, because I feel as if people don't really think about balance training by itself, you know?
Yeah.
That's really cool. One thing that I've always wondered about was sports like tennis and ping pong. I know that people say that those are some of the sports that you see that people actually live the longest. And because of, say, like the psychological, or they have to think really hard of like where they're going to hit the ball and stuff like that. Have you ever looked at any of those sports?
Not myself. I mean, I think ping pong is a very, they're both sports that involve power, muscle power, because you have to react very quickly and actually quite robustly in terms of the force that you produce, from different directions, different angles, and you have to kind of anticipate things. So it's a very cognitive sort of game and a lot of muscle power involved. Probably more aerobic capacity involved in tennis than in ping pong, but it's pretty heavy duty aerobic because they're pretty tachycardic as they're playing. So I think they're both kind of a really good combination of both physical capacity but also skill. They're obviously both the intense games of skill. Some of it you can't really teach Roger Federer how to look like that. Other people can play tennis, but they don't look like him, so some of that is something that you can't teach. Other is very much, something you practice for 10,000 hours, as they say, is what you need to become a master at anything, right? Whatever it is, learning a language or, 10,000 hours of practice is kind of what you need to get good at anything. And that's what they do. People who are the elite, racquetball and tennis and ping pong players, that is what they've done with their lives. So those games of skill are not so much about aerobic capacity or strength as they are about, that skill set that is, a combination of, their genetic endowment and their coaching and their, hours and hours and hours of practice. Yeah.
Yeah. No, very cool. And Maria, now I want to talk about a little bit of what you do, because I feel like it's something that doesn't exist much in medicine, especially in the US, and I think it's really important. You basically prescribe exercise to patients. What does that look like?
Sure. So I'm a geriatrician, which means I studied internal medicine and then geriatric medicine as a fellowship. And then my first sort of job after my fellowship was working in a lab in Boston, Tufts, and Harvard, where the actual invention of the term sarcopenia came about by virtue of Erwin Rosenberg, who coined the term there. So I worked in a lab, which was a sarcopenia lab, and they were doing lots of studies with exercise and glucose homeostasis, primarily, and aerobic exercise, as well as resistance. And I was also working in a nursing home as part of my geriatric rounds. And so we decided that, these nursing home residents would be excellent candidates for strength training because they were incredibly frail and could hardly stand up. And so we started doing studies of resistance training in frailty, and then expanded to lots of other chronic diseases like renal failure and heart failure and coronary artery disease and hypertension and arthritis and diabetes, obesity, depression, dementia, osteoporosis. So pretty much all of the diseases we studied looked like they had a benefit when you applied this kind of exercise. And often it was exercise that was doable even when aerobic exercise wasn't, right? So these people in the nursing home, they could barely walk, and you certainly couldn't prescribe any kind of robust aerobic exercise to them, but they could sit on weightlifting machines and lift heavy weights and, get stronger. So that's kind of where we started. And so since then, we've done lots of research studies, but I also have, we started a outpatient strength training center at a hospital, Balmain Hospital, my husband and I, about in 1999, actually, which was the first kind of center where people were getting geriatric medicine care, but it was also a gym essentially that we took over from the physios and put our weightlifting equipment in and started doing clinically as well as research studies in hip fracture and dementia there. And since then, I have a private practice version of that clinic in Pymble here in near Sydney, where I see patients as a geriatrician, so they're referred to me by their GPs or by other specialists. I do what's called a comprehensive geriatric assessment, which is a very comprehensive look at them from head to toe in terms of their diseases, their physical activity, their mental state, their nutritional state, their body composition. And I have 5 accredited exercise physiologists that work with me that then carry out the exercise prescription that I give them as part of their care. So it's not the only thing that I prescribe, because I do prescribe drugs or withdraw drugs they shouldn't be on, or do whatever testing they need. But what I do is incorporate mostly anabolic exercise, but also balance training and some aerobic exercise as part of the treatment of their diseases. So if they have osteoporosis or diabetes or heart disease, Parkinson's disease or dementia, whatever they have, if there is an evidence base that suggests that exercise is beneficial for that disease, then to me it's suboptimal to not be prescribing it. So it usually complements the drugs that they're on or sometimes replaces them. So if they're on an antidepressant and maybe it's not working so well and it might be causing falls, then my goal would be to withdraw the antidepressant, replace it with high-intensity weightlifting exercise, which we've shown in clinical trials is a very strong antidepressant. So everything we do is evidence-based. Everything is based on clinical trials or meta-analysis that show that, this dose of exercise works for this condition. And we stay away from forms of exercise that have not been shown to be beneficial, like gentle exercise or stretching by itself, or things that just haven't yet been studied for these conditions. So most of our patients are 80 to 100 years of age. Some of them are younger, 60 to 80, who have maybe severe osteoporosis or something else, but many of them are in their 80s, and they usually have, 10 or 12 diseases. A lot of them would be recovering from cancer or heart attacks or strokes, and even if they have, intercurrent events, they come back after they rehabilitate, after they have had their event in the hospital, then we, rehabilitate them from that and get them back on track. So, so that's what I do, as well as clinical trials in those areas as well.
Yeah, so based on everything that we talked about today, it's like a no-brainer that every doctor should be prescribing exercise. But why is that not happening in the U.S.?
It's not happening because in medical school, there's virtually no education about exercise at all for doctors. So there was none. When I went to medical school in 1977, I didn't have a single lecture on exercise, not one, in 4 years. Everything I learned about exercise, I learned by myself after I went to this sarcopenia lab at Tufts. I didn't learn about it in my residency either or in my geriatric fellowship. So all of those years of education, not a single lecture about exercise. It hasn't really changed for most medical schools. That's still the way it is. And for most residency programs, that's still the way it is. So you do hear about cardiac rehab, being a good thing to do, but you still don't even know what cardiac rehab means. Like you don't really know how to prescribe it or you've never seen it. So because it's not considered medicine, it's not taught, and then doctors have no idea how to prescribe it. And the most they can do pretty much is just say, well, I think you should take a walk, try and get a little exercise. But they certainly, they might know a little bit about aerobic exercise because it's more familiar and they've kind of heard, 150 minutes a week of moderate to rigorous. So they kind of heard that mantra for so long now that they know how to say that, but they don't actually know that that doesn't improve your bone density or that that doesn't prevent falling or that that isn't a treatment for sarcopenia. And they don't know anything about weightlifting exercise because, again, they unless they do it themselves, they don't know what it is. And they don't know that isometric strength training lowers your blood pressure by 10 millimeters of mercury. They certainly don't know that. So that's the problem. There's no education in it. And so you can't really blame them for not prescribing it. And there's no reimbursement for it. So if you look at something like diabetes prevention, for example, very large study, the diabetes prevention program, hugely well-known study in America, 3,500 people with obesity and impaired glucose tolerance, prescribed metformin or a control group or diet and exercise. And the metformin was about half as effective as diet and exercise in preventing type 2 diabetes, about a 30% reduction compared to 58% reduction. Metformin you can get paid for by your healthcare, insurer for life, at least in Australia, because it prevents diabetes. But diet and exercise, you can't get that paid for. And in fact, if you look at the study closely, metformin only worked in the young people. It didn't work in the old people at all. The old people, metformin was like a placebo for the prevention of diabetes. And yet, that's what we pay for. So the problem is that, because it's not considered medicine, it's not reimbursed by Medicare, as medicine, it's not prescribed in that way. It's really an ancillary kind of, pat on the back thing where, if you want to do it, you can, but, I'm not going to pay for it. So that's why I do it differently in my clinic. It is clearly medicine. My office is, surrounded by weightlifting machines. There's far more of them than there are of me. There's 5 EPs and 1 of me, because, to me, it's the core of good medicine for older people. And the older you are, the more you need it, which is kind of the opposite of what people think. So that hasn't happened yet. Will it ever happen? I don't know. But the problem is the education and the funding model. Those are the two problems as I see it.
So do you think that this financial aspect of not prescribing exercise influences the lack of education on exercise for physicians?
Well, I mean, I think, a lot of what you get taught in medical school is about drugs, obviously. There's a lot of connections between big medicine and big pharma, and when I was a radical medical student, we took all our Lilly stethoscopes and drove them down to Mexico to give them to the clinics because we were, adamant we were not going to accept, gifts from the pharmaceutical industry, which were rampant. So that subtle influence of either pharmaceutical companies being so in bed with medical education, not so subtle actually, is certainly part of the issue. And it's also, if you're taught about drugs for, hypertension, that's what you're going to prescribe because that's what you've been taught. So, and then of course, if people can get, their drugs reimbursed, but not their YMCA membership, well, they're going to go for the drug. And the drug's a lot easier in many ways, right? So there's so many disincentives to doing it otherwise that, I think that's the problem. So education is number one key. Dissolving the ties between big pharma and, medical education would be a good idea. That will probably never happen, but, that is part of the problem.
So do other countries like Australia and Germany, because I know Germany gives patients like money to buy gym memberships and stuff like that. Do they just not have this big pharma and big medicine connection?
Well, they probably still have it. I mean, it's everywhere, obviously. There's nowhere where it isn't. But there isn't there isn't the direct push. Australia doesn't have it either. I mean, if you're lucky, you might have a private health insurance that gives you a little bit of rebate on, on gym memberships, or you get, the government will pay for 5 visits a year to an EP, exercise physiologist in Australia, if your GP writes for that. But 5 visits a year is, not medicine, right? It's not like, here's your 5 metformin pills. Good luck to you, So it's on a completely different level than the way we treat drugs, And because of that, people don't take it seriously either. I say, well, if my doctor thought I should do it, he would have told me to do it, or my health fund would pay for it if I should be doing it. So it's hard to take it seriously when you look around and nobody's prescribing it, nobody's funding it. You kind of think, well, it must be optional, right? So that's what most people would think, is that it must be optional, when it's exactly the opposite of optional, really.
Yeah. What extent does lobbying play a role here, especially in like politics related to this? Are there any politics related to this?
Well, I mean, you can read a lot about big pharma and big food. I mean, if you look at General Mills, and there's a lot of lobbying that goes on, and there are people who have even thought that there are conspiracy theories here, because if you look at, what is corn syrup, right? Corn syrup is a byproduct of corn. They didn't know what to do with it. And the guy, General Mills, decided that instead of throwing all this stuff away, let's make it into a food that we put in everything, right? So corn syrup in various forms is in everything. And it's considered to be probably, the major cause of cardiometabolic disease that is, rampant, right? It's not fat. It's corn syrup. So, there are people who think that, this big food and big pharma are intensely connected because one is clearly profiting from what the other is doing. So that change in, the way that we eat has been huge in the 20th century. And, even like what people used to eat for breakfast, leftovers from dinner the night before, which was great, high protein, vegetables, right? And then when it switched to cereal, completely wrong thing to eat in the morning, low protein, high carbohydrate, lots of corn syrup, raising your blood sugar, causing insulin resistance and obesity. That was a marketing ploy to try and figure out what to do with all this excess cereal product, that needed to be fed to humans now because there weren't enough cows to eat it, right? So that's a complete shift, that, eating that cereal for breakfast as opposed to the leftovers from dinner, is probably a huge part of what has happened in terms of obesity and diabetes over the last century. So I think, to say that, that there's no, maybe it's not a conspiracy, but there certainly is knowledge that could have been had, like with the tobacco companies, right? Knowing for decades about smoking and not really saying much about it. I think the knowledge that this is bad has been there for many, many decades. But the interests are too big. The global conglomerate of big food and big pharma is so huge that pretty hard to oppose. Yeah.
Yeah, it's sad, but it's true.
Sad but true.
Did you have any ideas how to change that?
Well, I mean, you just have to, do what you think is right. And, I talk a lot about big pharma in my lectures sometimes about, things like antidepressants and, the falsities in the literature that are proposed, that are perpetrated. I mean, antidepressants is, I think I maybe have mentioned it, probably not in class, but if you look at, the antidepressant literature, right, which is almost all funded by pharmaceutical companies who make the antidepressants. If you look on the FDA website, you can see every clinical trial that's registered there because they all have to register their trials. And somebody has gone to the trouble of doing that and pointed out that if you look at all those trials, something like 98% of the positive trials are published, and about 95% of the trials that are negative are never published because you don't have to publish a trial. And there's not much, benefit to a drug company to do a study, show that it doesn't work, and actually publish that, right? And if you work out like the effect size of how important these drugs are for depression, it goes from about an effect size of about 0.6 to 0.3, which is a placebo effect size, right? And exercise is 2 or 3 times as effective as that in the clinical trials that are well done. So, there's a falsity and there's always a negative publication bias in the literature because people like to publish positive studies and journal editors aren't very interested in negative studies because they're not very interesting. So there's always a publication bias where you're much more likely to get a study published if it's positive. But this is extreme. This is clearly suppression of the evidence. And, I can send you this article later if you're interested. It was in New England Journal a few years ago. But it's very clear that, only the positive antidepressant trials are being published. And these drugs are clearly not as effective as they're said to be. And yet the market is enormous. I mean, they're one of the most widely prescribed class of medications in the world. Billions of dollars every year spent on antidepressants with an efficacy slightly better than a placebo, and lots of side effects. Younger adults, maybe not so bad. Older adults, falls, hip fractures, delirium, all sorts of confusion happen with antidepressants in older adults. And so that's a drug I'm always looking for. And I'm always on a mission to get rid of bad drugs. And that's the one I always am looking for and always trying to see if I can, substitute exercise and then taper it off if possible. I mean, not in everybody. There are some people who clearly need them, but there are an awful lot of people, who are being treated with them. They're not really working that well. They have side effects. No one's really bothered to stop them, and they're costing a lot of money. And the older you are, the more you are likely to get side effects from them. So yeah, I think there's, all you can do really is kind of one person at a time, do what you can. But, I think obviously we need drugs, and, drug companies, for the most part are probably trying to help people, but the problem is the for-profit industry. If it wasn't, right, if it was like, the polio vaccine, right? Salk, when he invented it, he said, no one will ever pay for this vaccine. No one is ever going to pay for polio vaccine because children are dying of polio. I don't want any child anywhere in the world to not get the polio vaccine. So he insisted that it would never have to be paid for by anyone anywhere. Not so true with the COVID vaccines, right? Where a lot of money, billions of dollars has been made from COVID vaccines and other kinds of vaccines. So, he had this idea that, that it's not right to make a profit off people's suffering. It should be a not-for-profit kind of venture to vaccinate children, right? And, I feel that medicine in general should be a non-for-profit venture. I feel like, it should never have morphed into a for-profit industry, which just needs to kind of constantly grow to feed itself. In my view, it really should be something that, that you make enough money to sustain whatever you're doing, but, you shouldn't be making profit off people's illness, So, again, I grew up in Berkeley, what can I tell you, in the 60s. So, that's my view on it, but it isn't the view of most people in medicine, I would say. Yeah.
So when it comes to the antidepressants that you mentioned, what effect do they have, and what effect does exercise actually have on improving mental health?
Well, I mean, for depression, like I say, they will improve it a little bit on average in most trials. When you compare them directly to exercise, the few studies that have done that have shown that exercise is as good or slightly better in terms of less relapse. In our hands, exercise, high-intensity weightlifting was about twice as good as referring somebody to a GP and getting either drugs or other kinds of treatment. So, and low-intensity weightlifting was actually just like a placebo. It was no better than that. So in our experience, the exercise is more potent. In the general literature, I would say that it's probably equal potent. And so you have a choice. You can give somebody antidepressants. You can give somebody exercise. The antidepressant may work for the depression. It's certainly not going to give them better aerobic capacity or strength or balance or prevent falls or treat diabetes or treat heart disease or treat cognitive impairment, whereas the exercise is. So if you had to weigh up, the cost-benefit analysis of which one is better to prescribe, there's no question it's exercise. Now, in a young person, it doesn't matter. If all you have is depression, you can treat it with a drug, you can treat it with exercise. The drug won't hurt you, fine. If you're 85, well, you've got a lot of other things besides depression. The drug might hurt you, so exercise wins. So I think you do have to consider who it is you're talking about. And clearly there are people with very serious depression who are suicidal, who are catatonic, who are psychotic, who have bipolar disease. They need drugs, absolutely, and counseling usually and other things, at least initially. But for the majority of people who, have moderate depression, I would say that where they're not actively suicidal, clearly have a choice of ways to handle it. CBT, exercise, drugs, they all work. Meditation, mindfulness, they all work. And so you need to kind of figure out the one that your person will do and the one that has the most benefit for the least harm, I would say.
Well, this was great. I love learning about Big Pharma as well. That was really cool. I had never heard about the antidepressant stuff. That's wild that they mute all of those negative trials.
I'll send you the study.
Yeah, that would be great. That would be great. But well, I think that clears up most of my questions. I know I always have stuff popping up, so
that's all right.
I'll definitely ask you in class. Yeah, but thank you so much for your time. I really appreciate it.
That's all right. Pleasure.
Thank you.
Thank you.
Thank you for tuning in to this episode of the Gustavo Franco podcast. We hope our exploration of the world of healthcare has been insightful and thought-provoking for you. The opinions expressed here are ours and of our guests, and should not be considered professional advice. This podcast is a collaborative learning experience for both the producers and listeners. While we strive to convey accurate and up-to-date information, we acknowledge that our research may have limitations. We encourage all of our listeners to supplement their knowledge by conducting their own research. If you enjoyed this episode and want to stay up to date on our future releases, make sure to subscribe or follow us on your preferred podcast platform and social media. We highly value your feedback, so please don't hesitate to reach out with your thoughts, questions, or suggestions for future topics. Together, we can foster a more educated America and contribute to a more effective healthcare future. Thank you for joining us on this healthcare exploration.